Thank you for having me again. So I'm going to talk about lung transplantation. I guess that was a great talk and it covered lots of aspects of IPF. And the next part is, well, when all else fails, what do you do? And so in some patients, not everyone, lung transplantation is an option, not just IPF, but other groups as well. My disclosures and what I hope to cover. So I'm going to give a bit of an overview of transplantation, both lung and heart-lung, because it generally falls upon the respiratory physicians to manage the heart-lung recipients. I'm going to focus on the adults, so I'm sorry if there are any pediatric people out here. The other thing that's really important, I guess, to discuss is who and when to refer these patients to a transplant centre. There are 4 transplant centres in the country, Melbourne, Sydney, Brisbane, and since 2004, Perth have one as well. And then I'm going to touch upon a few focus topics, because these are the things that are emerging, where transplantation is going, I guess, and that's where some of the clinical trials will come. So the first batch of slides are really coming out of the International Society Heart-Lung Transplant Registry, and it's just really great opportunity to provide an overview of what's happening in the transplant world. So this is looking at adult lung transplants over the years, and we see that the number of transplants just continuing to skyrocket. But what you notice is single lung transplants has been fairly steady, and all the growth is in bilateral, and that's essentially because there are better outcomes with bilateral. And that's just across, not just across a single disease entity, but across alpha-1 antitrypsin, COPD, and ILDs as well. We see that that growth in bilateral is occurring. If we look at why people are being transplanted, again, this is COPD, which is traditionally the highest indication for lung transplantation. But we see here our idiopathic interstitial pneumonia is increasing so much so that it's actually surpassed COPD in the cases that are reported to the registry. So it does represent the bulk of the international transplants. And this is driven in large part from the US of change to a lung allocation score, so sort of a more objective measure is how sick patients are and how they go on the waiting list. And according to that parameter, the ILD patients tend to score very well and get priority over the COPD patients, which we know tend to linger and suffer for a long time. And if you choose the patients correctly, you do get a survival benefit, but by and large, we transplant the COPD group for improvement in symptoms rather than survival. And there are some caveats around that, but that's, I guess, what to think about. If we look about their survival overall, so this is slightly busy, but I'll walk you through it. So the top 2 in the blue represent heart. So this is adult heart, this is pediatric heart and adult heart, and they tend to do the best. The red and the purple are lungs, and pediatric and adult essentially are the same, and then heart-lung do the worst. And pediatric and adults are again the same. So what we see, even though hearts do quite well, heart and lung together do quite poorly. And most of the mortality is actually quite early, and then it plateaus off. So it's that first year that has the risk. Within adults, so now I'm going to focus just on adult lung, and our slides are slightly cropped at the top, I'm sorry. But this here is just showing the double lung do better than the single lung. The other thing that we're seeing more and more of is retransplantation. So these are patients that get maybe benefit or some stability for a few years and then start to deteriorate for a number of different reasons. But again, if it's essentially a single organ problem, they get reevaluated on their merits and may be amenable to a retransplantation. Bearing in mind, they don't do as well as a general rule. And that's very much a case-by-case situation. Over the years and over the eras, so this is 1990 to 98, and then the decade following, and then the subsequent decade essentially, we're seeing improvements in outcomes, although it's sort of plateauing a bit. Within different diseases, we see different outcomes as well, which is not surprising. So across the top is our cystic fibrosis group. So although there's often multiple organ systems involved, they're quite young, they're fairly robust, and they actually do pretty well overall. In contrast, we've got our retransplantation group down the bottom. And then we have, which is it's not on this one, but we have a smattering of other groups in between. I don't actually have pulmonary hypertension on this one, but they tend to have an early mortality. But if they get through that, they tend to do quite well also. So there's really quite variability in depending on the indication. Why do they die though? And that's, again, quite a mixed bag. Early on, we see a lot of infection and a lot of essentially graft failure in the early stages. But as we go out to 5 years and beyond, we see this increase in the red line, which, according to this graph, it's OB or BOS. So that's obliterative bronchiolitis or bronchiolitis obliterans syndrome. It's actually not really the right term anymore, and we're moving away from that. We're moving to a term called CLAD, and I'll come to that a bit later in the talk. But essentially, this is our umbrella term for something's going wrong and we don't really know what. If we've got pathology, we call it OB. If we don't have pathology, it's the syndrome of OB, which is BOS. But it's more than just chronic rejection. It's failure for a whole host of different reasons. Risk factors for mortality. There are some recipient factors, so patients going in, if they're older, if they've got some biochemistry abnormalities, worse FVC or oxygenation, they tend to do worse. Some of the donor factors, the older they are, or the more malnourished the donor is, seems to have a bearing. And then the combination factors, so the longer the ischemic time impacts sort of 5 and 10-year mortality, and increased height difference between the donor and the recipient also affects outcomes. But mortality is only part of the story. There's also morbidity. If we look at the types of morbidity we're talking about, so rejection episodes, up to 30% of patients, or around 30% of patients will have a rejection episode within the first year. Chronic lung allograft dysfunction, which is the new umbrella term, and I'll come to that again, but that's quite common and increases in time. Infection, hypertension, diabetes is a big problem. A lot of our patients have unrecognised diabetes going in. By the time we give them a lot of steroids, essentially in that first year and beyond, we certainly push them towards being diabetics. Cancer, there's all sorts of cancer that the normal population are exposed to, but also there's PTLD, which is post-transplant lymphoproliferative disorder, and skin cancer is actually another big morbidity issue, and especially in Queensland and WA, where you've got significant sun exposure, it's a big and growing problem. And then final renal dysfunction, which we see early on. There's a lot of mild renal disease, and that just grows over the years, but so do patients initially on dialysis, and that grows, and even some end up with renal transplantation. So some of the poisons that we give to maintain the graft are actually quite toxic for the kidneys, and it's a balancing act, which is a lifelong balancing act between trying to preserve the kidney function and preserve the graft. Just a couple of slides on induction therapy and maintenance immunosuppression. Not all centres use induction therapy, so this is the use of induction agents at the time of transplant to sort of prime the immune system, I guess. There's a slight survival advantage. Probably about 70% of centres throughout the world are using induction therapy as standard. Essentially, it's a cost-benefit thing for the most part. In terms of immunosuppression, cyclosporine inhibitors are really the backbone of immunosuppression, and the introduction of these agents made a big difference in early outcomes. It's often coupled with an antiproliferative, either azathioprine or mycophenolate, and prednisolone is the other third agent. There's a smattering of mTOR inhibitor use, and again, that's used for a combination of things, either to preserve renal function, and there's some evidence also that it can reduce skin cancer risk as well, and that's very centre dependent. Just in contrast, I want to touch upon heart-lung transplantation. This peaked in the early 90s, so this is a number of transplants. We can see it's steadily declining, and in fact, it's something that's becoming less and less commonplace. There are fewer centres doing it. The centres that do it do fewer numbers as well. And this is because of that early mortality that we discussed. And if there's a way to just do, for example, a lung transplant and repair the heart defect, that would be preferred than doing a combined heart-lung transplant. If we look at the indications, again, a smattering of different indications, but over the years, all of the indications are actually declining for heart-lung transplant. And again, if we look at the survival, so I didn't stress before, but the survival for the lung transplant, adult lung, is about a median of about 7.5 years. And if you survive the first year, the median survival is about 10 years. Here we have a median survival of just 3.5 years, but it's all because of this early mortality in the first year. So if you survive the first year, then you've got a conditional survival of about 10 years beyond. So it's early mortality which is a problem. The reason why the lung doctors tend to look after these patients is because it's the airways disease that causes the big problem. So this is the freedom from either vasculopathy or BOS, and we see that this is the driver of morbidity and subsequent mortality as well. So moving away from the registry data, let's talk about patients and selection and who should get a transplant. And again, it's very hard to give an over-encompassing, but I'm just going to try and pull out a few salient points. Firstly, there are still some absolute contraindications, and these change over time, and if you're ever not sure, it's always best to touch base with the transplant centre, either by referring the patient or at least having a phone conversation. As a general rule, recent malignancy, so it's you've got to be 2 years cancer-free for a low recurrence risk cancer and 5 years for anything that's moderate, and there are some that probably will be lifelong. Untreatable, significant major organ dysfunction, so a little bit of renal impairment or liver impairment is not necessarily an absolute contraindication, but the bigger the problem, the more of a contraindication it is. Acute medical instability, and this is something that we might see sometimes in patients that have never been known to a transplant centre, present in respiratory failure, they end up in ICU, they're on ECMO, they're septic, and someone says, maybe we can transplant them. There are some centres that do that. The outcomes generally are not very good. There are a few that have been successful, but if there's things like sepsis going on top of everything else, it's generally going to be a bad idea. This is very dependent on the surgeons and the expertise, depending on what they're comfortable with. BMI above 35, we generally say above 32 in our centre, but again, there's variation. Documented recurrent non-adherence. Now, missing a few tablets at one point in your life doesn't necessarily rule you out, but a repeat offenders of non-adhering to therapy is an absolute contraindication. This is really tricky. A lack of a reliable social support system. I don't think we've ever actually said no to someone based on this, but it's a really tricky thing because you can't really measure it, and people can embellish, I guess, the supports that they have, but having a good framework is really important towards good outcomes. If they're really functionally limited with poor rehab potential, it's not just not doing well, but don't have even the potential to improve, that's a problem. And we send all of our patients to pulmonary rehab prior to transplant, prior to even formalisation of acceptance, just to sort of see where they are and what they can do. And substance abuse and dependence, obviously a major problem as well. There's a bunch of relative contraindications. I just want to highlight that things like Hep C, Hep B, HIV, they used to be absolute contraindications, now they're relative, and I think moving forward we're going to see perhaps that they're less and less of an issue. Timing of referral. So you get a patient, at what point do you engage a transplant service? Certainly if they're functional class 3 or 4, it's worth considering. If they're rapidly progressive, they're on maximal therapy, there's nothing else to offer them. Transplantation should always be kept in mind. Patients on oxygen, but there are disease-specific considerations. So you've got the IPF patient that potentially has the ability to go down the hill very fast. They should just be referred at diagnosis, essentially. Even if they're well, we can at least meet them, and then we'll see you in 6 months, whatever it happens to be. And again, no absolute contraindication. So unless there's very clear exceptional rationale for it, I won't see a patient that's still smoking, for example. Sometimes I've been asked specifically, can you see this patient? They need to understand why it's important to quit, and we'll have that conversation, but it's more about smoking cessation than transplantation. But when we see them, when do we list them? Essentially, the sicker they are, we're more likely to list them. Risk factors are things like hypercapnia, long-term NIV use, pulmonary hypertension, frequent hospitalizations, or it's rapidly progressive. All these things suggest that we should get on and put them on the waiting list. And again, there are some disease-specific considerations, and depending on the patient's blood group and size, it might be more difficult to try and find a suitable organ donor for them, so we might tend to put them on the list a bit earlier. I'm going to now turn towards a few little focus topics. So the first one is chronic lung allograft dysfunction, which is the new, umbrella term for what it is, chronic lung dysfunction, rather than using BOS, because it's not always accurate. So this is a recent paper sort of trying to put things in context. I'll just walk you through this because it's nice to have a framework. But essentially, you've got the lungs misbehaving, so it can either be acute, and it might be something that's identifiable, either acute rejection or acute infection or something else, or early on, you just suspect that this might be something that's chronic. And we define it really as an FEV1 and or an FVC of less than 90% that's sustained. If we have a specific cause, we try and treat that, and we may or may not reverse it. No cause either way. We can potentially end up with this definition here of CLAD, which is an FEV1 or FVC less than 80%, which is sustained for more than 3 weeks. And that's based on the patient's baseline, not predicted, but the patient's baseline. And within this, we're going towards this idea of restrictive clad and obstructive clad, and this is where BOS sort of sits. So this is why we're not using this as the umbrella term anymore, because it's a subtype of overall clad. So this is more of your obstructive picture, this is more of your restrictive picture. And what's coming out as we're, I guess as recent evidence, is we're starting to better understand this restrictive clad and the obstructive clad and how it impacts on prognosis as well. So this was a study looking at, again, my references have been cut off, I'm sorry, looking at RCLAD and the impact on survival, and also drawing out some phenotypes. So it's previously been shown that RCLAD has been shown to impact survival. So this is a multi-centre retrospective study, looked at CLAD as a definition of 20% drop in FEV1, and RCLAD was with the restriction element as well. And they wanted to validate the significance of this restrictive CLAD, also confirm that it's also a problem in single lung transplant, and try and look at risk factors for death after being diagnosed with CLAD. And as expected, they showed that this is your patients with bilateral lung transplant. These are the patients with restrictive CLAD, and they have a worse survival. So it's pretty grim, actually. So from diagnosis, we're talking, by 3 years, most of them have not survived. Single lung transplant, the difference is not as great, but it's still significant. So either way, restrictive CLAD is a bad thing. And they looked at risk factors, and the two main ones were restrictive, so having an FVC loss was predictive of poor outcome, but also if it happened early in the piece, so that's usually within 2 years of transplant, that was a poor prognostic sign. The other thing they looked at was, so you can get restriction on lung function, but you can also get patients that have relatively preserved lung function, but they get parenchymal or pleural fibrosis, and that, whether you've got the restricting element or you've got the scarring, either way, you have a worse outcome. And there's a large overlap between those patients with restriction and scarring. So the conclusion of that particular study was has worse prognosis in bilateral and single, and the additional risk factors for death after CLAD, prior rejection, early graft failure or grade 3 primary graft dysfunction at 3 days, female recipient, and prior organising pneumonia, which I haven't really drawn into, but they're just there. And there are particularly poor CLAD phenotypes. The other study that looked at this more recently in terms of phenotypes and how it impacts on outcome was this particular paper. This was a single centre retrospective, 300 bilateral lung transplants. Again, CLAD if the FEV1 was less than 80% of baseline, RCLAD if the TLC was less than 90. But they also had this thing, gas trapping, which was not radiological, but based on an RV-TLC ratio of greater than 50%. And they wanted to look at what was the outcomes, sorry, they're the controls, but they wanted to look at what were the outcomes from CLAD onset and whether restrictive CLAD or gas trapping CLAD were predictive of poor outcomes. The top one here, they've got their CLAD, which is non-restrictive and non-gas trap, and this is their outcome, versus restrictive CLAD. But if they do it the other way and look at the gas trapping CLAD, they also had a poor outcome. So these are not necessarily obstructive CLAD, but these are patients with an elevated RV-TLC ratio. And so from this study, we're really seeing that both restrictive and air trapping portends a poor prognosis. It's consistent with the prior studies about RCLAD, but we're also seeing this gas trapping phenotype is also a poor prognostic marker. And this is important for us because we see these patients, we really have limited evidence to support what to do next. So to know which ones are going to potentially stabilise and have a long time ahead, which ones are not and may require salvage therapy, which ones may require retransplantation consideration, having these phenotypes is really quite helpful. I'm just going to change tacks for the final part of the talk and talk about donor shortage. Every year patients die on the waiting list, and this happens both nationally and internationally. And there are a number of strategies to try and overcome this. We can extend the donor pool through donation after circulatory death. Now, people may have heard the term DCD. it's sort of gone backwards and forwards, whether we call it donation after cardiac death, but I think this is probably the appropriate term, donation after circulatory death, as opposed to donation after brain dead, which has been the traditional way that things have been done. We're also looking to use what we call extended criteria lung donors, or marginal lung donors, donors that are not the ideal lung donor. And finally, ex vivo lung perfusion, so that's taking lung out of the donor and putting it on some sort of mechanical device, a rig essentially, see if we can assess the lung, see if we can improve the lung before transplanting it. So I'll start with the extended donor pool and donation after circulatory death. So this is a recent meta-analysis that has just been published. 11 studies, 6 included in the meta-analysis, and they looked at 12-month survival. They looked at some other outcomes as well, primary graft dysfunction and acute rejection. And just by way of comparison, I think I've actually lost this other slide, and I do apologise. There was a nice forest plot, which I've deleted. But essentially, there was no outcome difference between the donation after circulatory death and the donation after brain dead. And this is actually local Australian and New Zealand data also showing no difference between brain dead donors and donation after circulatory death. And whilst I cropped off that slide, I do apologise. There are limitations. It was retrospective, observational, small cohort, and no difference in, no good assessment of long-term mortality, but there was no difference in outcomes, and it's certainly a viable source of increased donors. What's interesting, though, is in the US, they're very slow to pick up this donation after circulatory death, and you can imagine there's a lot of legalities and protocols in place that need to be established at each hospital that does this, and we can talk about that in the lunchtime break if anyone has any questions. I'm going to turn to the extended criteria lung donors. So just put things in context, when we're assessed with a potential organ donor, the ideal donor is someone less than 55 years, has to be blood group compatible, clear chest x-ray, good gases, smoking history up to 20 pack years, which I think is fairly generous, no chest trauma, major surgery, no aspiration sepsis, bronchoscopy looks pretty good. But that's actually pretty rare that patients fit that category. So this is a paper just published out of Melbourne, out of the Alfred group, and single centre retrospective 2-year study. And the Alfred actually, the largest transplant centre in the country, and they've traditionally used what we call extended criteria or marginal lung donors. They've got good utilisation rates, and they've got very good protocols in place for how to assess a donor and try and optimise that lung to make it workable. They used a donor score, which has been previously developed and validated, and looked at a whole bunch of outcomes, looked at early outcomes, looked at survival, and then some functional things at 12 months and elements of rejection. So this is the donor score that they use, putting into account age, smoking history, chest x-ray, secretions, and gases, and give them a score according to each one. Of their 318 donors assessed, 51% were local offers. Only 1% of donors were considered ideal. So clearly, there's a role for using these marginal or extended criteria donors. They don't use an EVLP program. Their survival, despite all of this, was greater than international benchmarks. And this is, I think, the really impressive slide. The utilisation rates. So compared to overseas data, these are local donors, so donors from Victoria. They use 61%, despite only 1% being ideal donors. And with that, they had survival outcomes better than international benchmarks. They also get a smattering of offers from around the country, and of them they use 41%. So really quite liberal in their use of what we would otherwise consider the dodgy donor. When they looked at the donor score and the significance of that on all of these outcomes, none of them were significant. When they looked at isolated aspects of the donor score on isolated outcomes, there were a few that drew out, but I think not particularly necessarily relevant in the overall scheme of things. So what we saw from these guys is that they've got excellent outcomes with marginal donors. The donor score was not associated with outcomes, although, as I mentioned, some individual scores were. It wasn't controlled for recipient variables, though. It's single centre, and we haven't really got long-term mortality data because generally they do very well, but also it's only a fairly recent study, so we haven't got the follow-up of that group as yet. And just to the final part of the donor shortage element is really EVLP. So this is looking at putting the lungs on rigs, as I've explained before. This is, again, the most recent study published this year from, I think it was the Patworth group that did this one. So it's a retrospective study, but they've used 10 years of data. And what they've really looked at, it wasn't specifically EVLP, it was looking at donors with an ischemic time of less than 12 hours versus more than 12 hours. They have got an EVL program in place, and about, I've got it coming up, but about 95% of these patients actually did end up on EVLP. So imagine this is essentially our EVLP group. And they looked at survival and also looked at early graft dysfunction. So this is the two groups, so less than 12-hour group on the left, greater than 12-hour group on the right. We see our EVLP is, yes, 95% of patients. They did have more donation after cardiac death, which is really circulatory death. The gases were slightly poorer in that group, and they had a longer preservation time, which is why they're in the greater than 12-hour group. Despite that, no difference. So it's really quite instructive. So we're saying that these patients, so longer than 12 hours, which is the EVLP group, does not affect outcomes. So it's really a potential to extend that donor pool. You can assess, you can optimise the donor lungs. It also has the ability to improve the geographic pool, and especially in Australia, where we've only got 4 transplant centres, but a widespread geography, the potential to get a lung from anywhere, put it on a rig, and then take it to where it needs to go has clear advantages. It also has some logistic advantages. If you've got centres where you've got minimal number of surgeons available, you can time the surgery for when you want it. You can do daytime surgery rather than middle of the night surgery, which is when it tends to happen more often than not. But there are limitations even for this study. Single centre retrospective. The greater than 12-hour group had more donation after circulatory death, and even though I've shown you data which suggests actually there's no difference, if anything, there's probably a trend towards better outcomes in this DCD group. The donors had lower PaO2, which would actually argue against them having similar outcomes. So again, it does suggest that it's a good outcome. It's a good measure to preserve and extend these lungs, and to overcome the donor shortage that we have. So that's the bulk of it. A few take-home messages. Changing pattern of transplant. So we've got increasing number of bilateral and decreasing heart-lung. Refer early if your patient is a possible candidate. It takes a long time to work up these patients, get to know them, assess the risks, minimise them, put them through rehab, etc. There is significant morbidity and mortality, so the median survival is about 7.5 years. If they survive the first year, it's about 10. This is something patients need to be aware of. It's not a great solution. It's a crappy solution to an even crappier problem. And they end up being chronic lung transplant patients. So we're replacing one chronic illness with another. CLAD is the new term, and there are phenotypes that are emerging. There's significant morbidity associated with transplantation, and there's a bunch of shortage strategies in place, and these continue to evolve. And I'm done. Thank you very much.